An effective diabetic retinopathy screening program screens all eligible people in a timely manner to enable early detection and management of retinal disease and prevent blindness. To achieve this ambitious objective, programs need locally appropriate screening protocols which balance available capacity against the cost of screening in the health system. Screening protocols set out when to first invite people with diabetes for their first eye examination, call, and then how often to re-invite them for re-examination, recall. There are international guidelines for use or adaptation in the local setting. These are based on the known evidence for the incidence and progression of diabetic retinopathy and diabetic macular edema. At the first screening visit, the recall decision is based on the level or grade of retinal disease identified. Patients with mild, non-proliferative or no diabetic retinopathy can be safely screened at 1 to 2 year intervals. They do not need referral to an ophthalmologist. Patients with moderate to severe non-proliferative diabetic retinopathy should be seen earlier. Moderate at 6 to 12 months and severe at less than 3 to 4 months. Patients with proliferative diabetic retinopathy should be seen by an ophthalmologist within 1 month, as they are at very high risk of sight loss. Patients with non-central involved diabetic macular edema do not require a referral to the ophthalmologist, but should be rescreened in 3 months and advised on blood sugar, blood pressure and cholesterol management. Patients with central involvement of diabetic macular edema are at high risk of sight loss and where possible should be referred and seen within 1 month by an ophthalmologist. Pregnant patients are at risk of their diabetic retinopathy increasing and should be screened regularly during pregnancy. Trained graders follow referral protocols to minimise any extra burden to the programme from false positives. Using a referral protocol is viable only if eye care clinicians are available to assess and treat the referred patients. Establishing and administering a robust call and recall system can ensure that no one is missed out and no one is screened more often than necessary. This involves creating and managing a regular list of people with diabetes from doctors' surgeries or pharmacy lists, ideally as an electronic database. Calling newly diagnosed people with diabetes for their first screening within 3 months of diagnosis. Capturing a detailed record of each screening event, and ensuring that the recall booking system invites each patient to attend their next screening at the correct interval. An important practical consideration for managing a diabetic retinopathy screening program database is that some people may need to be excluded or suspended from the database. People who are excluded from the database are those who cannot be treated for sight-threatening diabetic retinopathy. For example, someone with advanced dementia is not able to cooperate with instructions when undergoing laser treatment. People with no light perception in both eyes. Reasons for suspension from the database include children with diabetes under the age of 12 are at extremely low risk and don't require screening. People already under active ophthalmic treatment. They are returned back to the screening program once treatment is completed. People who choose to opt out of screening. For example, medical treatment for another condition can mean someone doesn't feel able to attend screening. A time limit of up to 3 years should be set for the opt-out. Recall systems run over the long term and need to be managed. By maintaining up-to-date records of all screening locations, including their accessibility, and screening dates and times. And providing each person with diabetes with appropriate and timely information about their screening appointment and the reason for it. Because the early progression of diabetic retinopathy is often symptomless, people with diabetes may not appreciate why they need to attend regular screening. The recall system must not be too frequent or unnecessary, and it must gain the cooperation of people with diabetes. Appropriately informing people with diabetes about screening includes providing them with all the information they need to make an informed choice to attend, providing relevant information in a language and method they can understand, and giving them the option to opt out of screening for a limited time after providing all the relevant information. Even in highly resourced settings, managing the acceptance and attendance of screening by people with diabetes can be challenging. Failsafe mechanisms to reduce loss to follow-up include employing a dedicated Failsafe officer, using software to manage the database which flags up people who have missed appointments, following up with people who have missed screening, either by choice or who have slipped through any gaps in the system, and ensuring good links between screening and referral centres to monitor people with diabetes being discharged back to the care of the screening programme. Call and recall systems should monitor coverage and uptake of the screening service, how many people with diabetes have been invited and how many accepted, and the number of people with diabetes lost to follow-up. In summary, people with diabetes must be called into a diabetic retinopathy screening programme in a timely way. The call and recall system must be coordinated through a nationally agreed protocol. Systematic call and recall through a dedicated administrative system can ensure good coverage and uptake of screening services and prevent blindness from diabetic retinopathy.